Hello. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's webcast, Thinking Long-Term, Data-Driven Decisions about PrEP. Today's program is supported by an educational grant from Gilead Sciences. I'm Dr. David Wall. I'm a professor of medicine, and I'm the site leader of the Global HIV Prevention and Treatment Research Site. I also co-direct the Viral Hemorrhagic Fever Clinical Research Group at the Institute of Global Health and Infectious Diseases here at the University of North Carolina in Chapel Hill. I am very happy to welcome Dr. Margot Savoy to the program. Dr. Savoy is Associate Professor at the Department of Family and Community Medicine at the Lewis Katz School of Medicine at Temple University in slightly less sunny Philadelphia. Welcome, Margot. So in our first module, we discussed how to open the conversation about sexual history in hopefully a non-judgmental way. And today, what we'd like to do is take the next step and apply clinical trial outcomes to the treatment decisions you're making for HIV prevention and consider long-term impact, especially on bone health, lipids, and renal dysfunction. So I think you'll remember that last time we saw our patient, Dylan, he'd come in for his annual checkup, and he asked about whether Dr. Savoy thought PrEP would be a good idea for him. And in the patient simulation, that caught Dr. Savoy, who I think did a fantastic job as an actor, caught her a bit off guard. And is it a good, I think it's a good jumping off point for us today as we think about, how do we consider what we should be thinking about when we initiate PrEP? And I thought it was a fantastic illustration of some of the opportunities and pitfalls. So, Margot, let's start with the basics regarding CDC guidance and who should receive PrEP.
Luckily for us, the guidance is pretty straightforward. There are basically two buckets of folks that you really should be thinking about prescribing PrEP for. One is adolescents and adults who are sexually active. And when we say sexually active, what we mean is anal or vaginal sex in the past 6 months. And in that group, you want to really focus on people who've had a known HIV positive partner. So if you know your partner is HIV positive, or if you have a personal history of having had a recent bacterial STI, or if they're inconsistent with condom use. So you don't necessarily have to get all three of the other conditions. One of them works, so that if I have inconsistent condom use, but my partner is HIV negative, or I haven't had any recent STIs, I might still qualify just because I have inconsistent condom use on its own. So it's just one of those other three. So that's one bucket of folks. And then the other bucket of folks is folks who inject drugs, or who have partners who inject drugs. So either if you or your partner injects drugs, then that's a concern. And so those are the two big buckets. The way that I think about it is that it's a pretty wide door of people that you really should be giving thought to. And I don't know that we always do a good job of that, which is why we're doing talks like today. Regardless of which group you're in, to begin PrEP, you do need to make sure that you document a negative HIV test. You need to confirm that they don't have any current symptoms of acute HIV. So remember, there's that window where you could have HIV, have acute symptoms, but not yet have a positive test. So you want to sort of make sure there's none of those symptoms going on. You want to confirm their renal function is normal and that they're not taking a bunch of other medicines that might be contraindicated. So things like NSAIDs or certain tuberculosis medicines or antiepileptics. And I do like to mention whenever we talk about this, that hepatitis B always comes up. So that people say you want to know whether they have hepatitis B or not, but it's not a contraindication to being started on PrEP. You just need to know because the medications can actually be used to treat hepatitis B. And sometimes starting and stopping can cause your concurrent hepatitis B infection to get worse. And sometimes that can cause liver damage. And so you just want to know that it's happening so that you can manage the patient appropriately, but it doesn't mean that they're automatically off the list from ever being able to have PrEP. So don't just take them off the list just because of that. I think it's important to remember that we have two options for prescribing PrEP. So you've got TDF and TAF. From an effectiveness perspective, like they're equivalent. So it's not like you have to pick one or the other because one happens to be so much better than the other one. So they're pretty equivalent. But you do need to know that the FDA approval is not the same for both. So that may impact how you decide. Both are generally safe and well tolerated, but their safety profiles have some slight differences. And that may matter for some of your patients. So for example, TDF tends to lead to higher plasma concentrations of tenofovir. I can never get that word out. And so that can sometimes cause kidney trouble or bone loss in folks. And that's less of an issue with TAF. On the other hand, TDF tends to lead to lower cholesterol and triglyceride levels, which might actually lessen some of the cardiovascular risk for particular patients. And TDF may actually cause some weight loss, which may be beneficial to some patients. So there may be a reason why you might pick one over other if you have the option to use either in a patient.
Terrific. So clearly, there's a lot to consider here, and I think that you spelled it out really nicely, both in terms of who might be a really good candidate for PrEP and what's available for PrEP. But let's narrow it down a little bit to the type of sexual activity. Tell me a little bit more about why that's important to figure out.
So, one reason it's important is that people who are engaging in receptive vaginal sex really only have one FDA approved option. So, TDF is the only one that's actually FDA approved in that particular group. So, it's not necessarily that you're going to do some harm to people, it's just that it's not FDA approved. And so, you need to be aware of that, particularly if you're going to need to be doing their prior auth and helping them to get their coverage and that sort of a thing. So, if they're at risk, but through receptive vaginal sex only as their only risk factor, then you may need to sort of limit their choice to TDF just because that's what's FDA approved. And so it's worthwhile asking the question. I do point out, though, that you've got to be really thoughtful about how you ask those questions, because for some patients, they do engage in multiple different kinds of sexual activity. And so if you're limiting in your questions, you may get a limited answer.
Excellent point. And another consideration we have is renal health, as we mentioned before. What do you have to say about renal health as far as our choices?
So renal health is important. And so like we bring it up because we know that there's a real impact of being on the medications and on kidney disease, but there's not as bad a thing as sometimes I think people get. So sometimes I think we get a little overexcited about it, but I do want us to talk about it because it matters. So you definitely need to evaluate their renal health before you start. So you want to know what baseline you're starting at. And if they've got a creatinine clearance of less than 60, you really shouldn't use TDF in those patients. So those are folks that really should not be on it. But you do want to have a baseline, and then you monitor about every 3 months that first time. And then after that, a lot of us will space out to every 6 months because it turns out that it's fairly stable. And if you're going to have a change, it usually happens early on. So you usually see that in that first 3 months. But there are some folks who have risk factors for having kidney disease who I think you might choose to pay a little more attention to or be a little thoughtful about who you're prescribing it to. So folks with diabetes or hypertension, people who already have CKD, people who are using stimulants or have a family history of cardiovascular disease, or, and this is a really big one, people who you have on medicines who you already know impact their kidney health. So if I've got a person who's on NSAIDs, so particularly things like diclofenac, where they really cause you a kidney hit in the first place, you want to be a little thoughtful about using TDF in those particular patients. There are some studies that continue to sort of explore like how common is this and how big a deal is it? And the reason that I say that we want to pay attention to it because it matters, because it is important, but fortunately for us, it turns out the risk is actually fairly small. So the cumulative risk was only about 2%. I think it was 1.7%. And so that's actually a pretty low number. And it was isolated mostly to older patients. So patients who are a little bit older and those who had some pre-existing renal dysfunction. So that's why checking in the beginning to know what baseline you're working with really, really helps a lot. It did turn out that when they studied it, TAF did appear to be less problematic to your renal function than TDF. But keep in mind that the rates in both of them were pretty low. And so for most of your patients, kidney disease by itself may not be a reason to just withhold PrEP or to stop them from being on PrEP. You may have a lot of a window to be able to work with them.
Yeah, interesting. So not a huge problem, but something to be mindful about.
Absolutely. Now, renal disease isn't the only thing that causes a problem. David, can we talk to them a little bit about bone health?
Yeah, certainly. I think that's the other side of the coin is the bone health. And while renal disease certainly is very uncommon, especially in younger people, we do have to think about bone health. And again, in younger people, as we know, adolescents and young adults, really almost to the age of 25 or so, are still developing their bone mass. And there is a concern about TDF. We have lots of data on TDF in people living with HIV, and as I'll show, in people who are taking TDF for PrEP. And we do know that there's a demonstrable decrease in bone mineral density in those who initiate TDF. And there's a lot of other factors that I think we have to think about when we think about bone health and risks for osteopenia and even osteoporosis, which is more advanced bone demineralization. And some of these are fairly common in people who are at risk for HIV acquisition, smoking, sedentary lifestyle, poor diet, alcohol use, methamphetamines, eating disorders, low vitamin D, and being really thin. So I think these are things that we have to worry about, particularly, again, in our younger people, maybe even more so than some of the renal issues. Next slide. And here's a really good demonstration of what we're talking about and maybe why TAF could be a better choice, I think, than TDF for those who meet the FDA indication medications for PrEP. And here you see a really nice demonstration of bone mineral density differences in the spine and hip in people who are in a clinical trial where they were assigned to TAF FTC versus TDF FTC. Both worked really well at preventing HIV acquisition. But you can see here that when we look at the percent of folks who had an increase in BMD or a decrease in BMD that was at least 3%, more people who were assigned to the TDF and took it had a decrease, a marked decrease in their bone mineral density over 96 weeks. So clearly TAF is more favorable when it comes to bone health. And I think that's another reason we should consider our options when we're talking to our patients. So in addition, we've talked about bone health, we've talked about renal health. Another really big consideration has to be adherence. And Margot, adherence is a tough challenge. And I know you spend a lot of time with your patients talking about this. And any thoughts about that?
Yeah, thanks for asking. So, what's really interesting to me is that chronic medications are just hard in general. And so that we're talking about it in the context of PrEP, but if you take care of patients, that it's just hard to remember to take a medication. And it's difficult, particularly when you're not sick. So you're not feeling not well. And so it's just not always on the top of your mind. But it really helps for people to do well, because when you do well and have a high rate of adherence, you get a 99% efficacy. So it works so well when we use it well, and it doesn't work so great when you don't. And so it's really important that we help people understand and do whatever we can do to help support them in using it well. In general, young people tend to have lower levels of adherence for medication in general, probably because they're just busy and they've got a lot of other things going on in their lives. They're just not thinking about it. They're also not used to taking a medicine every day. And so for them, it's not sort of part of their routine in life. There can be some other barriers that come up that are worth thinking about if it seems like it's happening in your patient population that you're taking care of. So things like concomitant substance use, if they're having any side effects. So if you're not talking to them about whether or not when they do take the medicine, it makes them feel some kind of way. And so that it's not even that they're forgetting, it's that they really hesitate because they don't know that they really like it, but they feel like they need to have it. And so then sometimes I take it and sometimes I don't. Sometimes that causes trouble. If they're having poor health status in general, so if I get sick and I'm not feeling well, I may be a little less adherent than I would otherwise be on the days that I'm feeling great. So if I have any other chronic medical conditions that might get in the way or sort of have exacerbations that might distract me, I may have trouble. If I perceive that my risk of HIV infection is actually pretty low, I may not do great on taking the medication. So that if I thought I was in a high risk relationship at one point, but now for some reason I think I'm not, I may now slide off a little bit on how often I'm taking my medication, but my risk may actually still be the same. And so it could be problematic if we're not realizing that and having that conversation. Inconvenience, if it's just not at a good time for taking it, if the pill size is too big, I don't really like having to remember to bring it with me. I have to travel a lot. Social stigma. I don't want everybody to know I'm taking this pill. I don't want them asking me questions. I don't want people to think I already have HIV. And so now they're asking me questions. And then honestly, we always have to remember just general social determinants of health. Cost and effectiveness and ability to get access to things can be affected by a lot of things that are not even necessarily about the individual. And all of these things, you don't have to have just one, right? So many of our patients are living a life that is complex and complicated and may include variations of all of these themes. And so we have to be thoughtful about talking to them about what it is that maybe is getting in the way, and if there's things that we can do to help them overcome it. I mean, I think about it as being a little bit bigger than just the individual. Are there some strategies, David, that you know of that have been demonstrated to really be effective at helping people?
Yeah, absolutely. And it really mirrors nicely the barriers that you have just identified. And we could think about this in sort of layers where we talk about the innermost layer being the individual, and then the provider, and then even bigger than that, the community and the society at large. And it really does mirror exactly what you said. So if for the individual, if remembering is a problem, then reminders. And nowadays, pretty much everyone has a little reminder in their pocket because they have a cell phone, and the cell phone can be set to remind people to do things. And I certainly do that. For others, pill boxes work really well. And there's all sorts of pill boxes, big ones, small ones, compartmentalized. And then also trying to tie this to something that someone does pretty much every day, like brushing your teeth, putting on your shoes. There's a lot of work that also goes into helping a person understand their risk and their perceived risk of HIV infection. And we see that in lots of different studies. There is a low perception of risk, despite there being on some qualitative and quantitative assessments, a real risk there that the person's underappreciating, and also understanding and buying into PrEP. That, no one takes a medicine who's ambivalent really well. So I think taking time to help understand the benefits of PrEP really articulating that because we know it, but our patients may not know it or appreciate it as well as we do. So really trying to help people get educated about why PrEP is so important and just how fantastically well it works. And again, this comes to the middle category of the provider support and provider rapport and trust. And I think communicating, and as you pointed out last time, really trying to do so in an empathetic way, non-judgmental way, and picking up on those cues and really trying to meet people where they are. There may even need to be some dedicated sessions just to talk about PrEP. And I think it's that important. And then ongoing support is really key, especially it may not be the clinician themselves, but others in the clinic who could help with adherence support and persistence. Writ large, we've got the society and the community, and you mentioned stigma, and you mentioned people feeling maybe negatively about taking PrEP or their need for PrEP. That's where support can come in. And if it's not from the family, which hopefully it would be, then peers. And trying to hook people up with other support systems that may exist within the community. And again, this could be something that is very empowering for people to stay on their medicines. We didn't talk a lot about it, but cost can be an issue, not so much for the medicine, given some of the support programs, and also insurance, but also just the cost of coming to clinic or missing work or some of the laboratory tests that may have to be done. So I think making sure that we have that kind of assistance available for people is going to be really important. So, we're going to get to some questions, and I think that's going to be really key to kind of fill in where there may be gaps in what we've covered in a relatively short time. But maybe to help wrap this up, Margot, can we talk a little bit about, SMART goals and some takeaways from our program today for folks?
Absolutely. So there are a bunch of goals that we really hope that you walked away from our little bit of time together with today. So first, we really wanted to emphasize to patients that PrEP is really highly effective. So it's not that you're taking something that's only going to work maybe. You're taking something that is absolutely going to reduce your risk. It's highly effective, but only if you're taking it daily. So you have to be taking it and adhering to it in order for it to work. So emphasizing that to patients is important. Factoring in some of the risk factors for some of the long-term negative impacts, particularly on bone health or renal health, are important. So just remembering that they exist. They're not necessarily, deal breakers, but you do want to pay attention to it. And so you don't want to scare patients about it, but you want them to be aware that these are things. And we want to take into account for folks who maybe have already pre-existing problems that we don't want to exacerbate them by picking one medicine versus the other. We want to be able to counsel patients about adherence on the follow-up visits, and then sharing strategies that maybe they may be able to implement into their daily lives to help promote adherence, so that you had some tools to be able to figure out what might I be able to offer to them as a suggestion in case you run into one of those barriers with one of your patients. And then truly recognizing that there are some things that are bigger than the individual, and that there are these social determinants of health that can negatively impact adherence that you may need to really take into account as you're helping the patient come up with a plan for how they're going to take their medication in a timely and safe way.
Wonderful. Great. So let's go to some of our questions. And I'll start with a really important one. Again, it gets back to bone health, which was what I was talking about before. And clearly, bone health is important for all of us. Are there foods or exercises or anything else we should be thinking about in helping our patients' bones stay safe, especially when we're talking about putting people on PrEP and also following them over time on PrEP?
I mean, for me, the way I think about it is that all these things have a relative risk, right? So if I'm going to put you on PrEP and I know that I'm giving you an opportunity where you might now have bone loss, then perhaps I need to be a little more thoughtful with sitting down and talking to you about calcium and vitamin D and about weight-bearing exercise and the things that maybe I wouldn't have thought about talking to you about until you were in your 60s or your 70s. I might want to just remind and mention that to you now in a younger age. I don't know that it necessarily means that every person needs to be started on calcium and vitamin D, or they need to put them on a medication, but I can certainly share with them the types of foods that are more rich in calcium and vitamin D and help them spend a little more time out in the sun maybe and get some vitamin D that way. And so you sort of help them come up with lifestyle things that can be helpful. And then you're just paying attention and watching to make sure that you're not letting something get out of hand. Well, for me, what often is the bigger thing is that we'll start off with this one risk factor that we know is happening, and then something else is going on. So they have asthma, and I end up having to put them on steroids a lot, or there's something else going on where I've now made their risk additive to something else. And those are the people that I really try to pay attention to, because in those cases, I feel like it's almost a setup. And then if you're not really thinking about, each one may be a smaller risk, but now together they become a huge risk, and you just want to be more thoughtful about it. How about you?
Yeah, no, I think that's really important. And again, as we talked about the risk of bone demineralization with TAF is much, much lower. And we didn't get into the why, but definitely we are not seeing the kind of bone changes we saw with TAF with TDF. That said, even when you are able to use TAF instead of TDF, there could still be, perception or rumors or buzz out there about PrEP and bone health that need to be addressed and countered so that the person doesn't mistakenly think that they're going to have a fracture because they're on PrEP. So we do spend time, regardless if you're on TDF or TAF, talking about bone health and understanding that there's other things people can do, as you mentioned, to keep their bones healthy, like not smoking, not drinking too much, exercising with weight-bearing exercise. And we have to think about those things. People are also on PPIs, proton pump inhibitors, and this can also demineralize their bones in addition to steroids. So I think bone health is really key. Vitamin D deficiency is pretty endemic. And so I think, again, we just have to really help our patients understand that, their PrEP is unlikely to cause anything clinically significant. And there's other things that are in their pocket that they can do to help keep their bones healthy, regardless of if they're on PrEP or not. So I think it's a really important conversation we don't usually have with people outside of PrEP, bone health in general and keeping your bones healthy. Sort of related is, and this is a good question, because I don't know the answer to this, and I think you do. So we know that methamphetamines and other substances can sometimes have a big impact on bone mineralization. But what about the ADD medicines or the ADHD medicines? Do they have an impact on bone health?
So technically, yes, but it's similar to what we've been talking about with sort of all these other things. Like it's an exposure and a dosing sort of issue, so that we don't tend to see it in rates that would make me necessarily say the person has to not be on medication, particularly if it's helping them with their other life activities. But technically, the answer would be yes.
Okay, good. So that it's something, just another straw that could, be on the scale that weighs it down towards more bone demineralization, and just something to think about when you're deciding what might be the right form of PrEP for people. And also maybe even checking, levels of vitamin D and addressing that if needs to be. And again, I think that that's an important thing. One thing I want to just clarify, because I know this comes up a lot, is we do not routinely order DEXA scans or bone scans in people on PrEP. It's not one of these things that it's such a big risk that we have to get a baseline test and then follow it over time. We don't. The risk here is really very low. And again, I think more and more as we use TAF instead of TDF, I think it really obviates much of the concerns that we have regarding bone mineralization and HIV prevention. And the same thing, and the same thing, I think this comes up a lot too, is, what about for renal function? Again, using PrEP, and do I have to be worried about medicines that could hurt my kidney, like over-the-counter nonsteroidals, which are used commonly? How do you address that?
So my answer is yes, but it's one of those yes with an asterisk. So it doesn't mean that if, I tripped and sprained my ankle and I had to be on an NSAID for a couple of days, that I have to now not use my PrEP. It's not that sort of a situation. But there are a fair number of people who are taking a lot more NSAIDs than we give them credit for on a day-to-day basis. And if you're taking high doses over long periods of time for particularly chronic medical issues that you already have going on, you've got to be careful about, doing too many things that are all going through your kidney. The perfect storm that I always think about is the person who is already on NSAIDs for their back pain, is using PrEP appropriately for their sexual health prevention, and then they get a UTI, and now you put them on, Bactrim, and next thing you know, they're now having renal failure because you sort of set them up. So you just get too many things. They're all trying to go through your kidney at the same time. So it doesn't mean that it's an absolute contraindication if you had to take naproxen, that you suddenly can never be on PrEP. It's not that type of a moment, but there are just certain NSAIDs, diclofenac, we know in general, that's why we don't use it quite as often for long periods of time. If I'm going to put you on diclofenac, I might want to be thoughtful about the fact that if you're also using PrEP, then I might cause you some trouble. We might have to think that through and have a conversation, or be a little closer and follow up, or think about other meds we might want to drop off while we're starting the other meds. So it's just more of a weighting and balancing of what the risk and benefits are for that particular patient and being mindful of it. But NSAIDs for me are particularly important because you can get them over the counter so freely, and people perceive them generally as being very safe. So what ends up happening is that they think if one is great, 4 must be better. And next thing you know, they're taking incredible doses that are really prescription strength, but you didn't prescribe it, so you don't realize it unless you ask the questions.
Yeah, really good point. And just to make it really clear, We are really honing in on some very unusual risks associated with PrEP. This is extremely well tolerated. Very few people stop PrEP of any form, TDF or TAF, due to any of these types of toxicities. And to be really clear, HIV itself is not good for the kidneys or the bones. So we really want to make sure that those who are at risk for acquiring HIV don't acquire the virus, because I think that would even be more quote unquote toxic to the organ systems that we're talking about. We're going to switch gears here a little bit and talk about something that's a little bit more wonky, and maybe about these new CMS regulations that require all formulations of PrEP plus lab work to be covered by insurance. What's been your experience with that?
So honestly, I was just reading about this the other day, like in the online, that they're passing the regulation to make it basically first dollar coverage. And if that's the case, to me, that's a blessing, because I
Yeah.
found that a lot of patients really struggle, particularly when you're trying to connect them on the medication side. That it can be difficult because even if you're able to use some of the prescription programs, the cost still ends up being a bit prohibitive, particularly for my adolescents who maybe don't have supportive parents who have the money that's going to be willing to pay for it, or they don't want to tell their parents that they're going to need the medication, things like that. It just becomes a little bit of a challenge. And so from that perspective, I think that it's really great. But you hit the nail on the head earlier when you were like, sometimes the medicine is covered, you're all good to go. And then you get a whopping bill for this HIV test or the renal function test that you didn't have some other reason to order. And you're getting this lab bill, or you've got a a deductible or some other issue that's going on that's really dropping these every 3 or 6 month tests on you. That can be pretty pricey and add up quickly. So for me, it's a blessing and a wonderful thing if we're able to get people both the coverage that they need from the lab side and the visit side, but then also adding the medication. It really just reduces such a huge barrier for so many.
It is a big deal. And so exactly, the vast majority of my patients have had no trouble getting the actual PrEP, but it has been, even though the laboratory burden for PrEP is pretty minimal. And we've talked a little bit about that last time, but I think that could be a barrier to people. A lot of the STI testing is more expensive than you'd think. So being creative about this in the meantime has been meaning us sending people to the health department to get their STI testing rather than our clinic where they might be charged. So really thinking creatively about this, minimizing the test to just those that are essential, as we've talked about, and as are in the guidelines. But I think this is going to be a blessing. It's going to really help folks be able to get really onto PrEP and not have finances, of all things, be a barrier to protecting yourself against HIV infection, which I think we can all agree is really, really not where we should or want to be. Well, this has been great. These are great questions. So I really appreciate this opportunity. And thank you, Dr. Savoy, for going through it with me. It's really helped me a lot. And then everyone else, thank you for joining us. If your colleagues missed today's program, we have 2 more opportunities for a live Q&A. That includes Thursday, July 22nd at noon Eastern, and then Friday, July 30th at noon Eastern as well. So please share this link with team members and colleagues. Stay safe, and thank you again for providing the best care for your patients.